Yeah.
Okay. Good morning, everybody. I'm Dr. Atul Kamath, and I'm representing the topic of mask-related ophthalmological problems. So, the introduction to assess the mask-related problems among eye care professionals and the same among the patients requiring eye care for the same. So, materials and methods. So, the among healthcare workers, we did a prospective randomized study of the eye care professionals for 6 months. And among the eye care professionals, what we did was a questionnaire consisting of total 8 hours of wearing masks, number of patients examined in the OPD, and along with difficulty arising with masks was assessed. And based on the assessment, the results were concluded. And among the patients, 350 of them were selected, and out of which a prospective randomized study of eye care among patients was done. A questionnaire again consisting of total hours of wearing mask along with difficulty in arising with the mask was assessed, and based on the assessment, the results were concluded. I've missed the introduction somewhere, so I apologize for that, sir. Yeah. Results. Among the healthcare workers, totally 50 eye care professionals had participated, out of which 10 were optometrists, 40 were ophthalmologists, and among the optometrists, they complained of fogging of trial glasses while doing the visual acuity correction, and among the ophthalmologists, they complained of fogging of the eyepiece objective and the 90-day lens on examination of the patient on slit lamp examination. They also complained of fogging of the operating microscope as well. Again, among the healthcare workers, when we assess for the dry eye syndrome, 10 of the healthcare workers developed dry eye syndrome, out of which 7 developed mild to moderate dry eye syndromes. These were the ophthalmologists. And among the optometrists, 3 developed dry eye syndrome. And total 90% of the healthcare workers developed healthcare headache and perspiration during the examination time, and 45 healthcare workers complaints of shortness of breath while examining and doing their work. And the average wearing of mask for the healthcare workers was around 10 to 12 hours. And among patients, 350 patients had participated, out of which the approximate wearing of their mask was 12, 10 and 8 hours respectively. And among 350, 225 were glasses who complained of fogging and fogging of their glasses in around 108 patients, which was around 48% of the patients. And among the patients, 80 of them developed mild dry eye disease, 22 or 20% developed moderate, and final 8 or 7% developed severe dry eye disease. Discussion. Study by Rosner et al. Found out that 314 respondents reported of adverse effects from prolonged mask use, like headache being the most common complaint. One more study by Moshirfar et al. Found that mask associated ocular dryness and irritation proved to be consistent in all mask wearers, patients and providers. And study by Crollo et al. Confirmed the existence of mask associated dry eye was more profound in females who had a prior history of dry eye disease, and if wearing a face mask for more than 3 hours had a more significant effect. Conclusion. With mask wearing being a dictum, actually it's because it's been removed by the government right now. So the examination of the patient for an ophthalmologist has become cumbersome. So the ophthalmologist should explain the patient about the potential ocular surface health risk and inadequately fitted masks. And applying dilute solution to the objectives may be beneficial while examining for healthcare workers. My references. Thank you, sir.
Thank you, Dr. Atul.
Thank you.
I had a question. Which type of masks have you considered for the study?
So, ma'am, this was the N95 mask which had become mandatory during the first and
So
second
everybody
lockdown.
was using
N95
N95,
masks,
the
ma'am.
valved ones or the
The white ones, ma'am.
valved ones?
Not the valve ones,
Not
ma'am.
the valved
Non-valve
ones.
ones.
Okay, so everybody was using the same type of
N95
mask.
masks, ma'am. That's what we had included.
Yeah.
So it's missing. Thank you, sir.
And when was this done, in the beginning of pandemic or towards the end of the
From the
pandemic?
first wave to the second wave, sir. In between that, we had done. It was very mandatory to wear masks. After the second wave, gradually the usage of masks came down, sir.
Okay.
Thank you, ma'am.
Yeah, the next presenter, Dr. Vidya.
Good morning, everyone. Digital eye strain in children. It's not moving. The digital eye strain is an emerging public health problem, and it's a range of eye and the vision-related symptoms with a variety of display devices. The prevalence has been reported to be 25 to 93 in various studies. The Portolo et al. Reported that the DAS symptoms are mainly due to the accommodation-related and the dryness-related issues. The aim of our study was to evaluate the children with the eye strain using the digital devices. It is a cross-sectional study done on children attending the pediatric ophthalmopedy with the complaints of eye strain. We have included the children between the age group of 8 to 18 years with these inclusion and the exclusion criteria. The questionnaire, which included the symptoms of the eye strain, hours of usage, the type of the devices were given, and they were got filled by the parents. Orthoptic evaluation was done in all these children, and depending on the results, we categorized into the accommodation excess, insufficiency, convergence excess, insufficiency, and the fusional convergence dysfunction. We had about 127 children, and the common devices used were the mobile, laptops, computer, and the iPads. The computer-based devices were commonly used in these children, and most of the children were using the devices for about 4 to 6 hours in a day. The common symptoms were the headache followed by the eye pain. Fusional convergence dysfunction is a common diagnosis we got in about 33% of the children. When compared the relationship of the diagnosis to the duration, we got the fusional convergence dysfunction and accommodative excess to be common with the increased hours of the duration of the devices. The association is more with the mobile-based devices. The symptoms were more pronounced with the iPad than the computer-based devices. It is the first study in literature to look into the cause for the DES. Most of our subjects experience a headache and the eye pain, which is in concurrence with other studies. The orthoptic abnormalities were seen in 93% of the children. Catherine et al. Found that the independent risk factors to be the smartphone and the viewing distance. In our study, we found the duration of the screen use to be proportional to the DES symptoms. So the limitations of our study being the cross-sectional design, the symptoms were assessed by the responses to your questionnaire, so recall bias is possible. Dry eye conditions were not assessed in our study. So I conclude by stating that DES is common with the mobile-based devices and with the increased duration of the screen use. The fusional convergence dysfunction and accommodative excess is associated with the mobile-based devices than with the computer-based devices. Proper evaluation for the cause of DES to be done and appropriate therapy need to be initiated. The healthier usage of digital devices to be taught to the children. Thank you.
So dry eye you've not assessed at all?
Actually, we have included that also, but I have not included in this presentation, sir. I have included in this study actually.
You evaluated in the
Yes.
children?
Yes, sir.
Okay.
Dr. Vidya, did you check the distance at which they were using the devices?
Yes, we have checked that also. For this presentation, I have not included. And we found that the distance, the lesser the distance, more the proportion.
Was it correlating?
Yes, it was correlating. I didn't include it in this presentation, but. Thank you, ma'am.
Good morning, everyone. Myself, Aishwarya Mahanti, is going to present on OCT, a new hope for lazy eye. Amblyopia is loss of vision with no organic defect. With a prevalence of 1 to 5%, it has become the leading cause of unilateral vision loss in children and young adults. About 50% of amblyopic children could not achieve complete vision of 20/20 despite appropriate treatment, which is attributed to structural and macular abnormalities. With the advancement of OCT, it has given a new horizon in understanding this etiology. My aim is to measure and compare the central macular thickness of amblyopic eyes with that of normal fellow eyes using SD OCT in the age group of 3 to 15 years. It was one observational case control study within a span of 1 year. My sample size was 46 pairs of eyes, out of which amblyopic eyes were cases and the normal fellow eyes were control. It included children between 3 to 15 years having an intraocular difference of 2 or more lines, with BCVA in amblyopic eyes 6 by 12 to 6 by 60 and that of fellow eyes 6 by 9 or better. Any previous history of ocular surgery, deprivation and bilateral amblyopia were excluded. A written informed consent was taken and a comprehensive ophthalmic examination including visual acuity, refraction, slit lamp and fundus examination and OCT examination. This is one of my patients undergoing OCT evaluation. Now coming to results and discussion, 63% of my cases belong to the age group 7 to 10 years. There was no significant difference between male and female in the occurrence of amblyopia. Regarding the types of amblyopia, 70% were anisometropic, 25% were strabismic and rest 5% were mixed. This table shows this comparison of CMT value between both the eyes. In anisometropic amblyopia, the amblyopic eye had 236 micron while that of non-amblyopic eye had 201 micron, and in strabismic amblyopia the results were insignificant. Firstly, my study found 26 anisometropic amblyops who had thicker CMT value in comparison to sound eye. To support this, Juan et al. Have proposed that arresting of apoptosis of retinal ganglion cells would lead to increase in macular thickness. Secondly, in strabismic amblyopia, there was no change in CMT value. Thirdly, 6 of my cases had thinner CMT value. Park presumed that it may be due to significant thinning of ganglion cell layer plus inner plexiform layer at macula. Emphasizing the pathogenesis, it is established that the pathology of amblyopia lies at lateral geniculate nucleus and primary visual cortex, but some recent studies have revealed it is associated with underdevelopment of retinal ganglion cells. Henceforth, the role of retina is still controversial. But with the recent use of OCT, it has made possible to quickly and non-invasively measure the retinal structure with its improved spatial resolution and scanning speed. There were certain limitations to my study. Firstly, the study had small subject number and the effect of amblyopic treatment could not be evaluated as the treatment history varied from no treatment to non-compliance with the treatment. To conclude, my study found anisometropic amblyops had thicker CMT value in comparison to sound eye, while that of the strabismic amblyops had no change in CMT values. In the end, the question again arises, can OCT be a new hope for lazy eye? In my opinion, yes, as it broadens the knowledge of macular structure associated with amblyopia and it helps in better defining it. It can be a future diagnostic tool and help the clinicians in predicting the treatment outcomes. We can also evaluate the effect of amblyopic treatment on the macular thickness. Therefore, OCT is highly recommended in moderate to severe amblyopia if certain macular abnormalities are suspected. Thank you.
Three-year-olds cooperated for the OCD?
Yeah, oh sir, that was some limitations. Some people they didn't, but OCT I took the parents with them, and with the help of the parents I did the study. But my below 5 years they were very less of my population.
Okay.
Which OCT you used?
SD OCT, ma'am.
Dr. Aishwarya, the significance in the CMT difference, was it statistically significant or was it just
No, it was statistically significant in anisometropic and
Yeah.
mixed. But in mixed, I had very few cases, so I couldn't comment on that. And in strabismic amblyopia, it was insignificant.
Right.
Thank you.
Thank you.
Shilpa next. Is there?
Dr. Shilpa. Dr. Nazma Begum.
Nazma is not here.
Dr. Parvez Ansari.
Good morning, everyone. I am presenting the case of role of 7% topical atropine eye drop for slowing progression of myopia in pediatric age group. First is introduction. Myopia is the most common developmental eye disorder. Usually starts during primary school and progress till main age of 16 years. Around 2.5 billion people by 2020 and half of the world population by 2050 will become myopic. In India, its prevalence was 2.1% in children aged 5 to 15 years. Around 2.5 billion people uh, by 2020 and half the population by 2050 will become myopic. If myopia progression can be reduced, myopia will be less in adulthood and therefore risk of complication will be lower. Common methods for slowing progression of myopia includes bifocal and multifocal spectacles, ocular hypertensive drugs, orthokeratology contact lenses, anticholinergic eye drops such as atropine and pyrazine eye drops. To date, atropine is the most effective medication for slowing progression of myopia. Atropine is a non-selective muscarinic antagonist. Its exact mechanism of slowing myopia progression is still unknown, but may be due to its anti-accumulative property and by regulating muscarinic receptor retina, choroid, and sclera, which prevent axial elongation of eyeball. Aims and objectives are to determine change in refractive error after administration of 0.01% drop in eye drop for 1 year, and to assess the change in axial length of eyeball using a scan, and to determine safety of 0.01% drop in eye drop by assessing its side effect. Material methods. Inclusion criteria are pediatric patient age group of 6 to 18 years and myopia progression which is equal or more than 0.5 diopter per year, and children having simple myopia in at least one eye. And if astigmatism is present in either eye, it should be equal to or less than -2 diopter. History of ocular trauma, surgery, keratoconus, corneal scarring, cataract, posterior staphyloma, coloboma, optic atrophy, pathological myopia, and allergy to atropine, amblyopia, retinal disease such as retinitis pigmentosa and trauma to retina are excluded. First come result and observation. This chart shows that uh, approximately 54% children are male and 46% are female, and um, in 7 to and 7 and 18-year age group there was no children, and most of the children are in 13 year and 17 years age group. This graph shows that pre-treatment mean axial length was 24.15 mm, and after 1 year of treatment it becomes 24.35 mm. So 0.2 mm mean axial length change what occurred, and in starting mean spherical equivalent was 2.37 diopter, and after 1 year of treatment it was 2.78 diopter. So 0.41 diopter increment occurred in refraction, while we included children which has equal or more than 0.5 diopter per year change in effective error. This graph shows distribution of study subjects according to myopia progression rate. This shows that approximately 50% children shows myopia progression less than 0.5 diopter per year. This chart shows that as age increases, change in myopia progression was decreased. Distribution of study subjects according to adverse effect. In 3% children transient photophobia and transient headache was seen, which was resolved after 1 minute, after 1 month. Discussion. For myopia, both genetic and environmental factors are responsible, but in recent time, increase in myopia cases appear because of environmental factors such as more time for near work and less time for outdoor activity. In our study, mean myopia progression of 0.41 diopter was observed, which was similar to 0.3 diopter progression in Jitendra Chinese study and 0.43 diopter in attempt to study. In our study, 0.20 mm of axial length change was observed, which was similar to 0.24 mm of attempt to study and 0.36 mm of lamp study. Transient photophobia in 3.84% and temporary mild headache in 3.84% children was observed, which was supported by Matthew Sachi et al. Study and G. Larkin et al. Study. Atropine effect does not depend on gender, supported by study conducted by Mihir Kothari et al. Our study limitations are short follow-up period, hospital-based study, so may not be represent the real picture at community level. Rebound phenomena after stopping the eye drop was not evaluated. Very few studies have been done till now, so further evaluation is required. Conclusion. 0.01% drop in eye drop may not be effective in each individual, and effect of 0.01% drop in eye drop does not depend on gender. To reduce the rate of myopia progression, atropine 0.01% atropine is significantly effective with minimal side effect. Thank you.
How did you measure the axial length?
By A scan ultrasonography,
Con-
three readings
Which
were
A
taken.
scan? Which A scan?
Contact or motion?
Contact.
So was it done by one person?
Yes, ma'am.
Like, was the user, like whoever was doing the A scan, was the standardized person doing it, or
I'm a resident. I think.
all different residents?
Yes, ma'am.
And why did you choose the age group 6 onwards, 6 years onwards?
Before 6 year, when during birth, children was hypermetropic, and up to 5 to 6 year, process of emetroporation generally completed. So after 6 years, children was included. In most of the study, they included children of 6 to 12 year, but we included children of 6 to 18 year because in some studies it has been seen that after 12 years, rate of myopia progression is still continued.
Did you have a control group?
No, ma'am.
So then how can you compare the axial lengths? How did you?
Axial length cannot be compared, but spherical equivalent was compared.
Okay. Okay.
Yeah, yeah, we have only done. We have already. Yeah, yeah, we have
We
already
will
into
be
time.
2 speakers. Yeah, he has.
We are in good time.
Dr. Hardik Patel, who is the next one? And
Good morning to everyone. My topic is a prevalence of refractive error and amblyopia and their association in a 5 to 15-year-old children. Introduction. Amblyopia is defined as a reduction of base corrected visual acuity of one or both eyes that can't be attributed exclusively to a structural abnormality of the eye. Amblyopia results from abnormal development of the visual system in early childhood. The visual cortex needs continuous, clear and focused visual impulses to develop normally. Children with amblyogenic risk factors, if not treated, are vulnerable to functional reduction of visual acuity causing amblyopia. Non predisposing risk factor for amblyopia are strabismus, refractive errors, particularly anisometropia and hyperopia, and visual deprivation such as a ptosis and a congenital cataract. Purpose of the study is to assess the prevalence of amblyopia among the 5 to 15-year-old children and to analyze the association between the type of refractive error and amblyopia. Material and method: a retrospective medical record review of the children between 5 to 15 years of age was carried out in Shivsa Medical College and Hospital, Gujarat. Duration period from August 2020 to July 2021. Inclusion criteria are: all the children between 5 to 15 years of age group are included. Exclusion criteria are the children less than 5 years and greater than 15 years of age, history of a premature birth, presence of the developmental delay or the neurological disease, presence of a systemic disease or a presence of any non-eye disease were excluded. Then material and method: all the children diagnosed with the refractive error were underwent the detailed ophthalmic examination. Examination included corrected and uncorrected visual acuity, external examination, direct ophthalmoscopy, cover test at far and near, cycloplegic, non-cycloplegic, and the subjective refractions. The diagnostic endpoint was a best corrected visual acuity of the less than 6/9 or a 2-line interocular optotype acuity difference. Chi-square test was done for the statistical analysis. Then results: in our study, 2,741 children were included in study. Out of them, 93 children were found to have amblyopia, and out of 93 children, 31 has the uniocular amblyopia, and the 62 children has the binocular amblyopia. So the binocular amblyopia was more than the unilateral amblyopia. Then age and gender-wise distribution of patient according to the amblyopia. We have found the no gender independent of gender, equal in male and female. Then average age of presentation was 11.158 plus or minus 2.78 years. Visual acuity in a amblyopic eye, we have found it that the most of the children has a visual acuity between 618 to 616. Then association of refractive error and amblyopia. In our study, astigmatism was found more, then followed by the myopic astigmatism, hypermetropic astigmatism, then myopia, then hypermetropia. Discussion: the prevalence of amblyopia in our study was 3.39%, which is comparable to other studies. Prevalence of refractive error was 23.20%. Patient with visual acuity between 618 to 660 have the higher degree of the amblyopia. Result from the study clearly depicts that the amblyopia was independent of gender. Myopic astigmatism was most common in amblyopic eyes. Therefore, the uncorrected refractive error was commonly associated with the amblyopia. In conclusion, as per the finding of our study, refractive error is a major risk factor for the amblyopia. Therefore, it emphasizes the need for visual screening of young children and management of refractive amblyopia at appropriate time. Thank you, sir.
Now, why do you think myopic astigmatism was the main cause of amblyopia?
No, ma'am. Astigmatism and refractive error are all are the.
In your study, myopic astigmatism you've written, no? 58%, something like that. 50 plus.
Myopic astigmatism are found more.
Why?
In general, refractive error are more associated with amblyopia.
What is your study?
Uncorrected refractive error.
Is there any explanation for myopic astigmatism causing more amblyopia? Did you find any?
Because children age group are the more vulnerable to myopic refractive error.
What did you take as the criteria for monocular amblyopia and binocular amblyopia?
Visual acuity, Snellen chart difference. Visual acuity 6.6 is in a fellow eye. Then we included that is the uniocular amblyopia.
6.6 and 6.9 will be uniocular amblyopia.
Less than 6.9 or 6.6.
And binocular?
For binocular, less than 6.9 or in both eye, 6.9 to 6.12.
What can be the other causes of amblyopia in this age group other than refractive error?
Any congenital ptosis or cataract or strabismus or any meridional amblyopia. Thank you, sir.
Dr. Mahesh Krishnan Trivedi. That's it.
Dr. Mahesh is not here.